directly by YouTube.
Okay.
Okay, great.
Well, good afternoon to you all, ladies and gentlemen. It's a pleasure to be back with the autumn session of the Morphology series for the Congenital Heart Academy. And as you can see from the image that is in front of you at the moment, our question today, what is congenitally corrected transposition? Now you see I've also already given you the easy answer to that question, because it truly is the triumph of sequential segmental analysis. And that is what we're going to be demonstrating to you over the next 45 minutes or so. But why were there problems? In the past, this lesion has been described in various ways. For a long time, it was called ventricular inversion. Now, many of you will know, if you've heard me recently, or indeed if you've heard me for years now, I dislike the term inversion, because what we're going to be discussing today is not so much upside downness, which is the vernacular meaning of inversion, but it is mirror imagery. And we're going to hear that again and again today. It has been called even worse terms. The excellent pathologist Maurice Lev called this lesion mixed levocardia, but that doesn't really help anybody. Nowadays, all too often, we see the lesion called L transposition. We're going to discuss this in some length, because in most instances it is in fact that the aorta is positioned anteriorly to the left, but this is not always the case. So we can't use L transposition, as we will explain, as a synonym for congenitally corrected transposition. So what we need to do is we need to look at the abnormal junctional arrangements that underscore the lesion that we prefer to call congenitally corrected transposition. Now, it has a long history. This is the man who first described it. This is the Baron von Rokitansky. The Baron was the foremost cardiac pathologist of the 19th century. He practiced in Vienna, and this is the picture from his atlas where he shows us the first known example of congenitally corrected transposition. And you see, he shows you a short axis view looking at the base of the heart from the apex. And this is exactly how nowadays echocardiographers will show you congenitally corrected transposition. So we need to look at the anatomic arrangement that produces the lesion we are discussing today. And to emphasize again, it is abnormal segmental connections. So there are discordant connections across the atrioventricular junctions. And then the situation that congenitally corrects the arrangement is the fact that there are also discordant connections across the ventricular arterial junctions. It can occur usually in either the usual or mirror imaged arrangement of the atrial chambers. We're going to show you that also. But it excludes the situation where you have double inlet ventricles. There can be left-handed topology with double inlet ventricles, but that is not congenitally corrected transposition. It also excludes the situation where we have isomeric atrial appendages or absence of one or other of the atrioventricular connections. So what are we discussing? We are discussing discordant connections. So another thing we hope to clarify today is the relationship between atrioventricular discordance and discordant atrioventricular connections. Because as we are going to explain, these are not quite the same thing. So we'll get to that in the fullness of time. But first, let's look at what we do mean by discordant connections and look at how they produce congenitally corrected transposition. So I'm going to start off by showing you some diagrams. So here we have the situation with usual atrial arrangement. As you see, I've put a label on the morphologically right atrium, which is right-sided. Now, because of the discordant atrioventricular connections, the morphologically right atrium pumps the blood into the morphologically left ventricle, and this is right-sided in most instances. But then we have discordant ventricular arterial connections, and this is the key, because in recognizing the fact that we have dual discordant connections, the blood goes back to the lungs. So it's going the right way round, despite the fact that we have the discordant connections. So the blood comes back, the left-sided morphologically left atrium, but now it enters the morphologically right ventricle. And the morphologically right ventricle is on the left side, and in most instances, but not all, it gives rise to an anterior and left-sided aorta. So this is congenitally corrected transposition when we have usual atrial arrangement. But we can have exactly the same thing when the atrial chambers are mirror imaged. And of course, when we have mirror imagery at the atrial level, the morphologically right atrium now is left-sided. Now, because of the discordant atrioventricular connection, the blood's going to come into the morphologically left ventricle, but the left ventricle now will be left-sided. It will be where you expect it to be for the otherwise normal heart. And then, because of the dual connections that are discordant, the blood is going to go back to the lungs through the pulmonary trunk. So the circulation has been corrected, comes back to the right-sided morphologically left atrium, and then enters the morphologically right atrium, right ventricle rather, which is where we expect it to be. And then, again, in most instances, the right ventricle pumps the blood into an anterior and right-sided aorta. This is congenitally corrected transposition with mirror-imaged arrangement, but as you will see, it is not L transposition. So to emphasize again, L transposition is not the same thing all the time as congenitally corrected transposition. So here you've seen the situation in diagrammatic form, and what I've emphasized is that the two discordant connections cancel each other out, and that is what potentially corrects the circulations. And most usually, it is found with usual atrial arrangement, and because of the mirror-imaged ventricular mass, there is left-handed ventricular topology. But you've heard enough of me for the time being, so let's look at this in a video that's been prepared for us by Diane.
This heart has congenitally corrected transposition. The aorta lies to the left of the pulmonary trunk, and it has been cut just prior to the bifurcation of the brachiocephalic arteries. We see the superior and inferior cable veins joining a morphologically right atrium. So here is the blunt triangular tip to the appendage and the broad attachment with the venous component. Looking inside of the right atrium, we see the characteristic pectinate muscles around the right atrioventricular junction. Here's the coronary sinus and the flap valve at the floor of the oval fossa. The oval foramen is probe patent in this case. Guarding the inlet, we have a morphologically mitral valve, which will always travel with the left ventricle. It's supported by paired papillary muscles, and there are no attachments to the septal surface. The morphologically right atrium is connected to a morphologically left ventricle, so that we have discordant atrioventricular connections. There are the fine crisscrossing apical trabeculations that are the morphologic determinant of the left ventricle. We can see that smooth septal surface towards the outlet component of the ventricle. And here there is fibrous continuity between the mitral valve and the pulmonary valve. This is the pulmonary trunk exiting the left ventricle and dividing or bifurcating into the right and left pulmonary arteries, so that now we have a discordant atrioventricular and ventriculo-arterial connection, but the flow of blood is still going the right way around. Looking at the left side of the heart, we see the pulmonary veins draining into this left-sided atrium, which we can confirm is a morphologically left atrium with its tubular appendage and the narrow attachment to the venous component of the atrium. When we look inside, the atrial vestibule is smooth. Here is the left side of the flap valve, which you can see is propatent, and the pectinate muscles are confined to the appendage. So this is a morphologically left atrium. The inlet is guarded by a morphologically tricuspid valve that has one of the associated malformations seen with congenitally corrected transposition, namely an Ebstein's malformation. There's also a bit of dysplasia to this valve. It is a morphologically tricuspid valve because there are attachments to the septal surface and attachments to papillary muscles. The tricuspid valve will always travel with a right ventricle, so that on the left we do have a morphologically right ventricle with its coarse apical trabeculations. So here we have discordant atrioventricular connections on the left side as well. Within the outlet, the aorta is supported by a complete muscular infundibulum. So again, discordant atrioventricular and discordant ventriculo-arterial connections. This ventricle does exhibit left-hand ventricular topology, as I can only place the palm of my left hand on the septum with my thumb in the inlet and my fingers in the outlet. The interventricular septum is intact in this case with congenitally corrected transposition.
So now you've seen the regular situation for congenitally corrected transposition. And in that heart that you saw, there was an anterior and left-sided aorta. But is L transposition the same as congenitally corrected transposition? Let me emphasize again, that is not the case. Why? Because the aorta is not always left-sided when we have congenitally corrected transposition. It is usually right-sided when congenitally corrected transposition is found with mirror-imaged atrial arrangement. More importantly, we can find a left-sided aorta when we have regular transposition. So let's now look at an example where we have regular transposition, but the aorta is left-sided.
This specimen has usual atrial arrangement and transposition or discordant ventriculo-arterial connections. So there is our morphologically right atrial appendage to the right and our morphologically left atrial appendage to the left. You can see that the right ventricle has coarse apical trabeculations and trabeculated septal surface, and that the aorta does arise from the morphologically right ventricle. It's also important to note that this specimen shows us right-hand ventricular topology, so that only the palm of my right hand can be placed on the septal surface with my thumb in the inlet and my fingers in the outlet. You'll also note that the aorta is anterior and leftward of the pulmonary trunk. You'll see the right coronary artery passing in front of the pulmonary trunk to reach the right atrioventricular groove. So in the terms used by Van Praagh, the usual atrial arrangement is the S for situs solidus. The D is the D loop, or right-hand ventricular topology, and the L in this case would be the left-sided aorta. So the important point to note here is that you can have regular transposition and still have a left-sided aorta, or in Van Praagh terms, SDL.
So, hopefully that's got L transposition out of the way. You will remember now that when I was describing the basic arrangement, I said that the double discordant connections potentially corrected the circulations. And I use the term potentially on purpose because usually there are additional problems. And there is a triad of associated anomalies that we expect to find in the setting of congenitally corrected transposition. They're not all present at the same time, but in the greater majority of cases, one or other of these lesions will be found. So they are a ventricular septal defect, obstruction of the left ventricular outflow tract, and problems with the morphologically tricuspid valve. So now we're going to look at those, and again I'm going to introduce the situation with some diagrams, and then Diane will show you the real thing. So let's start with ventricular septal defect. In fact, the majority of patients with congenitally corrected transposition have a deficient ventricular septation, deficient ventricular septum. And as you would anticipate, in the majority of cases, those defects are perimembranous. And the rules for determining the phenotypes are exactly the same as they are for patients having concordant atrioventricular connections. So the perimembranous defect will have fibrous continuity between the leaflets of the mitral and tricuspid valves. And almost always in congenitally corrected transposition, the defects are perimembranous. Rarely they can be muscular. And as you would anticipate, those muscular defects to the inlet, to the apex, or to the outlet. And even more rarely, on occasion, the defect can be doubly committed. Now, there is a potential problem here, because I hope you will all remember that when we analyze ventricular septal defects, so as to determine the phenotypes, we look at them from the stance of the morphologically right ventricle. So when we make these decisions, we should remember, as Lucille Hoyel from Paris has emphasized, we should be looking at the defects from the morphologically right ventricle. And that is the point that Diane is going to emphasize when she shows you some hearts of congenitally corrected transposition with ventricular septal defects.
In this segment, we're going to look at ventricular septal defects, but I think it's worth mentioning some of the other subtle variations that we can see in this group of hearts with congenitally corrected transposition. Here, the apex of this heart is roughly to the midline, and you'll note that the heart even has a roughly square position with almost a straight or flattened apex. The aorta and pulmonary trunk are related such that the aorta is nearly directly anterior to the pulmonary trunk and a bit leftward. So when we look at ventricular septal defects in the normal heart, we look at them from the right ventricular aspect, and that's how we establish their borders and their geography. So it only makes sense that in hearts with congenitally corrected transposition, we should look at the same borders and geography from the morphologically right ventricle. So here's our morphologically left atrium with its tubular appendage, pectinate muscles confined to the appendage, and a smooth atrial vestibule. The morphologically tricuspid valve is guarding the inlet to this morphologically right ventricle. We can see there are septal and papillary muscle attachments. And then the right ventricle has its characteristic coarse apical trabeculations, which are its morphologic determinant. So this ventricular septal defect is a central perimembranous ventricular septal defect, so that it lies just behind the zone of apposition between the septal leaflet and, now in this heart with congenitally corrected transposition, the posterior most leaflet rather than the anterior superior leaflet. And there is our medial papillary muscle. Here we see the subaortic muscular infundibulum within the left-sided morphologically right ventricle. So again, we have discordant ventriculo-arterial connections. The septomarginal trabeculation is giving rise to the cephalic arm, which rises up to become part of the muscular infundibulum, and the caudal arm, which in this case extends to reach the inner heart curvature, so that the supraventricular crest is inserting normally between the limbs of the septomarginal trabeculation. As I mentioned before, this is the medial papillary muscle, and the borders of the ventricular septal defect tell us that this is a central perimembranous ventricular septal defect, so that the caudal arm of the septomarginal trabeculation reaches the inner heart curvature, and there is fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior border of the defect. If we look at the defect from the morphologically left ventricle, here we see the fibrous continuity between the right-sided morphologically mitral valve and the arterial valve, which in this case is the pulmonary valve. And there is our ventricular septal defect. The posterior inferior border shows us that there is fibrous continuity between the mitral valve and the tricuspid valve. This heart also has a ventricular septal defect, but I wanted to first point out that the apex of this heart is pointing to the right. Also, look at the relationship between the aorta and the pulmonary trunk. They are virtually side by side, with the aorta a bit anterior and leftward of the pulmonary trunk. I'm going to go right to the outlet portion of this left-sided morphologically right ventricle. You can appreciate the coarse apical trabeculations. The septomarginal trabeculation is here, with the cephalic arm rising up to be incorporated into the subaortic infundibulum. The caudal arm does not reach the inner heart curvature, and so the ventricular septal defect lies within the limbs of the septomarginal trabeculation, so that this is an outlet ventricular septal defect. The tricuspid valve and the mitral valve are in fibrous continuity along the posterior inferior border. Looking at the left side of this defect shows us that fibrous continuity along the posterior inferior border between the mitral valve and the tricuspid valve. And the fibrous continuity in this specimen is a bit broader than it was in the previous specimen. We're looking at another heart with congenitally corrected transposition that is an explanted heart, so that the majority of the atriums and arterial trunks have been previously removed. The morphologically left atrium is connected to a morphologically right ventricle on the left side, and Guarding the inlet is a tricuspid valve. You can see that the tricuspid valve is mildly thickened and that there is a defect beneath the septal leaflet of the tricuspid valve. There are chordal attachments along the crest of the ventricular septum. Looking at the outlet component of this morphologically right ventricle, here we see that there is a prosthetic aortic valve previously placed, and this is our subaortic muscular infundibulum. The septomarginal trabeculation is here, with the cephalic arm rising up to be incorporated into the muscular infundibulum. The caudal arm in this case does not reach the inner heart curvature. So that along the posterior aspect of this defect, we have fibrous continuity between the mitral valve and the tricuspid valve. This defect extends into the outlet of this right ventricle. And remember, I also said that it was extending to the inlet, so beneath the septal leaflet of the tricuspid valve. This defect is then consistent with a confluent defect. Looking at it from the left ventricular side, you can see the crest of the ventricular septum here, and that portion of the left-sided tricuspid valve that is straddling and overriding the ventricular septum. Here is the fibrous continuity between the mitral valve and the tricuspid valve along that posterior inferior aspect of the defect. Also, there is the fibrous continuity between the mitral valve and the pulmonary valve. So I'll just reiterate again that we should describe ventricular septal defects as seen from the left-sided morphologically right ventricle, just as we describe them in the normal right ventricle from the right ventricular side.
So the next situation is pulmonary stenosis. Now here, I'm just going to show you diagrams to illustrate what is going on in pulmonary stenosis. The lesions are primarily found within the ventricle. So the same situations that produce some pulmonary obstruction when the ventricular arterial connections are discordant will produce subaortic obstruction should the connections be concordant. So what are the problems? We can have valvar stenosis. And in congenital corrected transposition, of course, that will be pulmonary valvar stenosis. But over and above that, we can have tissue tags, or most importantly, we can have a fibrous shelf. And if you look at the picture on the board at the moment, you'll see there's some green structures just in front of that fibrous shelf. And this, of course, represents the conduction axis. We'll come to that in the fullness of time, but I'm going to introduce you to the significance of the conduction axis in the setting of congenitally corrected transposition. But let's first of all look at a tissue tag. So here I've opened the outflow tract from the right-sided morphologically left ventricle into the pulmonary trunk. And you can see there is a ventricular septal defect, but blowing through the ventricular septal defect from the high-pressure morphologically right ventricle, which of course is the systemic ventricle, we have this tissue tag. And on occasion, surgeons have unpicked those tendinous cords that are attaching the tissue tag to the margins of the ventricular septum, and they've used the tissue tag to close the ventricular septal defect. And tissue tags are quite frequent in the setting of congenitally corrected transposition. But this is the really troublesome lesion. Again, I'm showing you a close-up of the base of the morphologically left ventricle, which of course is right-sided. We're looking at this from the apex of the ventricle. And again, we have a perimembranous ventricular septal defect. But what I want to emphasize here is the shelf that is producing subvalvar pulmonary obstruction. But now look what is seen and glistening on the subendocardial surface of this morphologically left ventricle. Because with the eye of faith, we can see the course of the atrioventricular conduction axis. We're going to come back to this shortly when we look at hearts to show you where it is. But in this picture, you can see that the axis is running anterocephalad relative to perimembranous defect. More importantly, it is running through that subpulmonary fibrous shelf. And this is a problem because, certainly a problem for the surgeon, because you can't remove that subpulmonary fibrous shelf without destroying the atrioventricular conduction axis. But as I say, we will come back to the location of the atrioventricular conduction axis. Now, this is subpulmonary obstruction. On occasion, the entirety of the outflow tract can be atretic. And in most instances, we find that with a ventricular septal defect. So now Diane is going to show you a nice example of congenitally corrected transposition with discordant ventricular arterial connections, but with the discordantly connected pulmonary trunk being atretic. Congenitally corrected transposition with pulmonary atresia and ventricular septal defect.
This heart with congenitally corrected transposition has its apex pointing to the right and has usual atrial arrangement. The aorta and pulmonary trunk, as they exit the ventricular mass, are arranged such that the aorta is anterior and leftward of the pulmonary trunk. You can already appreciate the discrepant size between the aorta and the pulmonary trunk because there was pulmonary atresia in this case. The aortic arch went to the left with usual branching of the brachiocephalic arteries. The branch pulmonary arteries were of good size in this case. There is the right, and the left has been cut, but we can see how large it is as it enters the root of the left lung. The pulmonary arteries were most likely of good size because they were fed by an arterial duct. And also in this case, an aortopulmonary shunt, which has since been taken down during pathologic examination. The atrioventricular connections are discordant in this case, with a morphologically right atrium connected to a morphologically left ventricle. And secondary to the pulmonary atresia, the left ventricle can become very hypoplastic in some cases. It is slightly hypoplastic in this particular case. The mitral valve is supported by paired papillary muscles. There is one, and it's quite interesting that the other papillary muscle in this case is very hypoplastic. There is a ventricular septal defect, and if we check the outlet, we can see that there is indeed pulmonary atresia. So there is no outlet from this right-sided morphologically left ventricle. The left-sided atrioventricular connections are also discordant with a morphologically left atrium accepting the pulmonary veins and draining into a morphologically right ventricle on the left side. The inlet is guarded by a tricuspid valve, which actually has gotten torn during examination, but it is attached by tendinous cords to the septal surface and to papillary muscles. The morphologically right ventricle has left-hand ventricular topology, and arising from it is the aorta. So again, discordant atrioventricular and ventriculo-arterial connections. The ventricular septal defect, if we look at it from the right ventricle or the morphologically right ventricle, we see that it is an outlet defect as it lies within the limbs of the septomarginal trabeculation, and it extends to become perimembranous because there is fibrous continuity of the mitral valve and the tricuspid valve along the posterior inferior aspect.
So now you've seen the usual fashion in which we find pulmonary atresia in the setting of congenitally corrected transposition, but very rarely we can find it with an intact ventricular septum. And now the features have much in common with pulmonary atresia and intact ventricular septum with concordant connections, but it is the morphologically left ventricle which is hypoplastic. So in many ways, this is a cross between pulmonary atresia and intact ventricular septum and the hypoplastic left heart syndrome. So let me show you a nice example of this combination that is present in the archive of Lurie Children's Hospital in Chicago. So here you see the close-up of that hypoplastic left ventricle, and the arrow is showing you the blind-ending pulmonary trunk, which is atretic down to the ventricular-arterial junction. The left ventricle itself is does not only have a very small cavity, it's also hypertrophied and thick-walled, as it is in hypoplastic left heart syndrome with concordant connections. And there you see the atretic pulmonary trunk, pulmonary outflow tract rather. You can also see a little bit of the tension apparatus of the valve, which, because of the discordant atrioventricular connections, is going to be the mitral valve. And when we look in the morphologically right atrium, we see that the mitral valve is also imperforate. So here we have the combination mitral atresia, pulmonary atresia with intact ventricular septum, giving us, if you like, a form of hypoplastic left heart syndrome, but in the setting of congenitally corrected transposition. So let's move on and let's look at the third of our triads. And these are the lesions involving the morphologically tricuspid valve. And the characteristic lesion is the ebstenoid malformation. And almost always that is associated with valvar dysplasia. But we can also have straddling and overriding of the morphologically tricuspid valve, and that gives us a spectrum to doubling left ventricle. But what we're going to concentrate on is the ebstenoid malformation. So again, let's ask Diane to show us an example of the abnormalities that typically involve the morphologically tricuspid valve.
We're going to look at some of the associated malformations that we see in hearts with congenitally corrected transposition. And here we're looking at the left atrioventricular junction, so that we have a morphologically left atrium connected to a morphologically right ventricle on the left side of the heart, so discordant atrioventricular connections. The atrioventricular junction is guarded by the tricuspid valve in this case, which you'll see is a bit dysplastic, and as well there is an Epstein-like malformation, so that we can look at the normal hinge point of the tricuspid valve along the line of my probe, and here you can see the actual hinge point along this portion of the tricuspid valve. It has failed to delaminate, and the hinge point is actually rotated downward. The hearts with congenitally corrected transposition and Epstein malformation typically do not have atrialization of this portion of the right ventricle, whereas this heart is out of the norm and actually does have thinning of the adjacent ventricular myocardium. So that again we can have valvar dysplasia and hearts with Epsteinoid malformations associated with congenitally corrected transposition.
So now you've seen the chamber connections that give us congenitally corrected transposition. You've seen the lesions which we typically find in this setting. We now need to look at the things that go along with it. And first of all, we're going to look at the coronary arteries. And as you might expect, they reflect the ventricular topology. But to understand their arrangement, we need to look at their sinusal origin, their epicardial distribution, and then we can analyze any malformations as we would in the setting of transposition with concordant atrioventricular connections. And as you all know, we do that by considering ourselves as the little surgeon. We're standing in the non-adjacent sinus of the aortic root. We're looking towards the pulmonary trunk. And then we analyze the origin of the major coronary arteries from the sinuses of the aorta. And in the usual example of congenitally corrected transposition, we find that the morphologically left coronary artery, supplying the right-sided morphologically left ventricle, is to the left-handed sinus of the aortic root. And this, of course, is sinus number 2. So here we don't have the problem of the hands not corresponding with the coronary arteries. So with our little mannequin sitting in the non-adjacent sinus, we then see that the morphologically right coronary artery is arising from sinus number 1, and that is the right-handed sinus. And there is not nearly as much variation in sinusal origin of the coronary arteries as we find in regular transposition. In fact, the most frequent lesion is a solitary coronary artery. But let's ask Diane to show us the typical example of the coronary arteries in the setting of congenitally corrected transposition.
We're going to look at the coronary arteries as they are associated with congenitally corrected transposition. And we've already looked at this heart, and we know that it has left-hand ventricular topology. The epicardial distribution of the coronaries will be determined by the topology in each specific heart. Here we know that we have usual atrial arrangement with a morphologically right atrium to the right and a morphologically left atrium to the left. The aorta and pulmonary trunk are virtually side by side in this case, with the aorta slightly anterior and to the left of the pulmonary trunk. I'm going to tilt the heart up on its apex so that we can look down into the aortic and pulmonary trunks. So this is the aorta, this is the pulmonary artery. You can see the bifurcation to the left and right main pulmonary arteries. So what I'm going to do is effectively stand in this non-adjacent sinus within the aorta. So the sinus that's farthest away from the pulmonary trunk, so that this sinus and this sinus are the adjacent sinuses. This non-adjacent sinus is what some people call the non-coronary sinus because it very rarely gives rise to a coronary artery. So if I'm standing in this non-adjacent sinus, my right hand will go towards the right-facing sinus, or to sinus number 1. My left hand will go towards the left-hand facing sinus, or sinus number 2. So that when we look at the coronary orifices as they exit the aortic root, we can see one in sinus number 2 and one in sinus number 1. So these are the sinuses adjacent to the pulmonary trunk. If we look at the coronary artery arising from the right-hand facing sinus, or sinus number 1, we can see that it is morphologically consistent with a right coronary artery. And this is the typical pattern when you have usual atrial arrangement. So that the right coronary artery will arise from the aorta and give rise typically to an infundibular branch and what some people call the conal branch. And then the right main coronary artery will encircle the tricuspid valve orifice, or run within the left atrioventricular groove. This coronary artery usually gives rise to the inferior interventricular coronary artery, and in this case gives rise to a few small branches that track over the left ventricle, which is right-sided in this case. So dominance is typically decided on which coronary artery gives rise to the inferior interventricular branch. If we move to the other coronary arising from the left-hand facing sinus, or sinus number 2, we see that there is a short main trunk, and it immediately branches into the anterior interventricular coronary artery and a circumflex branch. The interventricular coronary arteries, both anterior and inferior, give a good indication of where the ventricular septum is located. The circumflex artery continues into the right atrioventricular groove or surrounding the mitral valve orifice. So here it extends and actually becomes very fine at its termination over the anterior wall of the right-sided morphologically left ventricle, so that in this case we can clearly see that the right coronary artery was dominant, as it gave some branches to the inferior aspect of this morphologically left ventricle that is right-sided, and it also gave rise to the inferior interventricular artery.
Now, the other major abnormal feature, and I've touched on this already, is the atrioventricular conduction axis. And we now know that in most instances, that conduction axis arises from an anomalous atrioventricular node. Now, to understand what's going on, we need to take into account two features. And the most important of these is atrioventricular septal malalignment. But without question, this is also influenced by the topology of the ventricular mass. So as you know, in most instances, we have left-handed ventricular topology. And that means that almost always, not only will there be septal malalignment, there will also be an abnormal atrioventricular conduction axis. The situation is not quite the same when we have right-handed ventricular topology. And here there has been some confusion, in part because of the cases that have been studied to demonstrate the location of the conduction axis. Most have had some degree of pulmonary obstruction, and that gives better alignment between the atrial and ventricular septums, meaning that very frequently in this setting you can have a normal conduction axis, but when there is septal malalignment, you can have the anomalous atrioventricular node, just as you would find it in the situation of left-handed topology. So if we look at a typical example of left-handed topology, usual atrial arrangement, this is how the surgeon would see the situation looking through the right atrium. The key point: the connecting node is no longer going to be in the triangle of Koch. Instead, it is located anterolaterally and beneath the mouth of the morphologically right atrial appendage. So if the surgeon looks into the ventricle, I've shown here a rather extravagant ventriculotomy with a perimembranous ventricular septal defect. The key feature: the conduction axis is going to run anterosuperiorly relative to that perimembranous ventricular septal defect. So here's what it looks like in diagrams. Let's ask now Diane to demonstrate the features of the abnormal conduction axis using specimens.
It is the role in hearts that have left-hand ventricular topology that there is atrioventricular septal malalignment. So in this heart with congenitally corrected transposition, the pulmonary valve is wedged between the mitral valve and the interventricular septum. So we will have an anomalous conduction axis. The conduction axis will arise where the atrial myocardium joins the ventricular myocardium, so in this anterior superior position, and it will extend anterior superior to the pulmonary valve and then take its normal course over the interventricular septum. This specimen with congenitally corrected transposition has a perimembranous ventricular septal defect, and the conduction axis as well will be abnormal because there is left-hand ventricular topology and atrioventricular septal malalignment. Here we can see nicely where the atrial myocardium joins the ventricular myocardium, so that our atrioventricular conduction axis will be in this area. It will then extend in an anterior superior position to the pulmonary valve and down along the superior aspect of the ventricular septal defect.
There are other problems, because when we have congenitally corrected transposition, oftentimes the heart is in an abnormal position, and frequently it is right-sided with a right-sided apex. And that abnormal position can then be made worse either by tilting of the ventricular mass to give us supero-inferior ventricles, or, more importantly, by rotation of the ventricular mass. And that can create great problems because it gives us the so-called crisscross heart. So if we take the typical situation and we tilt the ventricular mass rightwards, that gives us supero-inferior ventricles. The other problem is twisting of the ventricular mass, and this is what gives us crisscrossing of the atrioventricular connections. And if you look carefully at the diagram I produced, you see now we have a right-sided aorta. So this comes back to that hoary old question. This is transposition SLD. It is D transposition, but it is still congenitally corrected. So to emphasize again, L transposition is not the same thing as congenitally corrected transposition. But let's finish our consideration of discordant atrioventricular connections by looking at those other ventriculo-arterial connections that can coexist with the discordant connections at atrioventricular level. And we're going to start by asking Diane to show us some of these close cousins.
We're looking at the short axis from the base of a heart that is a close cousin to congenitally corrected transposition. This heart was transplanted, that's why we don't have the atrial chambers and the arterial trunks. From this aspect, we see the aorta arising directly anterior to this very large pulmonary trunk, and we know that we have usual atrial arrangement with a morphologically right atrium and appendage to the right, and a morphologically left atrium and appendage to the left. If we look at the right atrioventricular junction, we see that it is guarded by a morphologically mitral valve that has only papillary muscle attachments and no attachments to the interventricular septum. The right-sided ventricle is a morphologically left ventricle with fine crisscrossing apical trabeculations and a smooth septal surface towards the outlet. So we have discordant atrioventricular connections. You'll also note that there is a very large ventricular septal defect. The mitral valve straddles and overrides this ventricular septal defect and also has a true cleft, so that this cleft points directly at the outflow tract rather than at the interventricular septum. There is no outlet to this morphologically left ventricle on the right side, and this heart does have a double outlet right ventricle. We'll see that in a moment. On the left, we have a morphologically left atrium and atrial appendage. The atrioventricular junction guarded by a dysplastic tricuspid valve. You can see it has a curtain-like posterior-most leaflet that is somewhat thickened, and there is also an epsteinoid malformation along the inferior aspect. I apologize for the heart falling apart as it was improperly sectioned initially, and I've tried to glue it back together. So here we have the epsteinoid component of this tricuspid valve, where the true hinge point would be here, and you can see where this portion failed to delaminate. The ventricle on the left side is a morphologically right ventricle with its coarse apical trabeculations. As well, you can see the septal attachments of the tricuspid valve and the papillary muscle attachments. The outlet to this left-sided morphologically right ventricle has the aorta supported by a complete muscular infundibulum, and as well there is the pulmonary artery exiting this ventricle. So there is a double outlet right ventricle with discordant atrioventricular connections. Also, the mitral valve is straddling and overriding this ventricular septal defect with a large papillary muscle towards the outlet and smaller papillary muscles within the left-sided right ventricle. So there's the crest of the ventricular septum, and you can see this component of the mitral valve straddling and overriding the ventricular septum. I will mention in this heart that because of the double outlet right ventricle, the atrioventricular septal malalignment is not as severe, and the atrioventricular septum is a bit more aligned so that the ventricular septum is reaching the crux of the heart in this particular case, which may allow the conduction axis to form in a more normal or usual position. Also, I'll note that there is a fibrous component here created by the tricuspid and the mitral valve, so that this is a perimembranous ventricular septal defect.
So you've seen one of the close cousins, but very rarely discordant atrioventricular connections can be found with concordant ventricular arterial connections. And it's very important to recognize this combination, since in this situation the surgeon can use atrial redirection, because already the morphologically left ventricle will be supporting the systemic circulation. And we're going to show you pictures of an example of this again from the archive, the Idris archive at Lurie Children's Hospital in Chicago. So here is their beautiful heart with discordant atrioventricular connections, but concordant ventricular arterial connections. So here is the right-sided morphologically left ventricle. Now the arterial trunk arising from this ventricle has been cut off short. And at first sight, it's difficult not to think that this is a pulmonary trunk. But in fact, it is the aorta, because there you see it is giving rise to a coronary artery. There's another abnormal feature in that it has a completely muscular infundibulum. And then it has mitral to tricuspid continuity inferiorly relative to this interventricular communication. So because of this, we know that the conduction axis is going to be running anterocephalad when this defect is viewed from the morphologically right ventricle. So here we have discordant atrioventricular but concordant ventricular arterial connections, giving us flow patterns of regular transposition. And then we can have other close cousins. We don't have time to discuss these with you today. We can have left-handed topology with isomeric atrial appendages and transposition, or we can have univentricular atrioventricular connections with left-handed topology. They are related to congenitally corrected transposition, but they are not the same thing. So let's finish by coming back to the question I posed much earlier in our presentation. Is atrioventricular discordance the same as discordant atrioventricular connections? And the answer here is an unequivocal no. The term atrioventricular discordance was introduced by my good friend Richard van Prague, and he used it to define ventricular disharmony. Now, what do I mean by ventricular disharmony? You'll all know that in the typical arrangement with situs solitus, we have right-handed ventricular looping or de-looping. And with situs inversus, as described by Dr. van Prague, we have right-handed ventricular topology. We usually have left-handed ventricular topology or L-looping. So Dr. van Prague noticed that in congenitally corrected transposition, we have SL rather than SD, and in the mirror image variant, we have ID rather than IL. But Dr. van Prague also noted that these could be found with double inlet ventricle or with tricuspid or mitral atresia. So in his original approach, any heart with SL or ID has atrioventricular discordance. Now, unfortunately, we did not appreciate when we introduced our concept of sequential segmental analysis. So we distinguished between discordant connections, double inlet, and absence of an atrioventricular connection. But sadly, we used the term atrioventricular discordance. Now, Dr. van Prague at that time did not accept our concept of connections, since he argued the segments were not connected together because of the presence of additional connecting segments. So, for better or worse, he veered away from describing connections and introduced the concept of alignments. But is this really justified? Now, if we look at the developing heart, there's no question that we have these connecting segments. This is a 4-chamber cut through such a heart at 5 weeks of development, and you can see one of those connecting segments, the atrioventricular canal. The other connecting segment is the proximal part of the outflow tract or tonus. But very rapidly, that atrioventricular canal becomes sequestrated on the atrial side of the atrioventricular connections, as the vestibules, and with ongoing development, the proximal outflow tract also becomes incorporated within the ventricles. So by the end of the embryonic period, we can say the ventricular mass extends between the atrioventricular and the ventricular arterial junctions. And by that stage, there is no question but that the cavities of the segments are connected together. And because of this, the components of the segments are not necessarily aligned. So alignments are not necessarily the same thing as connections. And now Diane is going to show you that using a congenitally malformed heart.
This specimen has usual atrial arrangement and the classical type of tricuspid valve atresia, so that there is a morphologically right atrium to the right and a morphologically left atrium on the left. There are also concordant ventriculo-arterial connections with the pulmonary trunk arising from the hypoplastic right ventricle. You can see the characteristic muscular ventricular septal defect, and I'd also like to point out that this right ventricle has right-hand ventricular topology, so that I can put my thumb towards the inlet and my fingers towards the outlet with my palm on the septal surface of the right ventricle. The specimen has, by Van Praguian terms, atrioventricular concordance, where there is alignment between the right atrium and the right ventricle. But you can see I can lift the right atrial floor off of the ventricular mass so that there is no connection between the right atrium and the right ventricle. So with absence of an atrioventricular connection, we have atrioventricular alignment, but it is not the same thing as having a concordant atrioventricular connection.
So we can now answer our question. What is congenitally corrected transposition? It is the combination, discordant atrioventricular and discordant ventriculo-arterial connections. How do you now make the diagnosis? Without question, you must first determine the morphology of the segments themselves. Now you need to determine how they are joined, or in some instances, how they are not joined across the junctions between them. I hope we've shown you there can be no question but that the segments are connected together, so connections are a real thing, and most importantly, it is those connections rather than the way the cavities of the segments are aligned that determines the way the blood goes round. So hopefully we've answered the question, what is congenitally corrected transposition? So there we are, folks. Norman, do you want to say a few words? You're muted, I think.
Can you hear me now, Bob?
I can hear you now, indeed.
Great. Well, wonderful session. I missed the very...
Norman, do you want to say a few words?
I think I'm talking, Bob.
You are? We've got that echo again. Carry on, I think.
No, I'm not muted. I can see my audio is working now, Bob.
I can hear you now, indeed.
Great. Well, wonderful session. I missed the very...
Norman, you have to close YouTube. You have YouTube channel open?
I have to close the YouTube. Okay, let me just close the YouTube. I'm going to do that. No, I'm not muted. Okay, so now I'm here on the session.
Now it's okay.
And you can hear me. Bob, the only thing that I really want to talk about is that as echocardiographers, the sinus hands are looked at from below upwards. And so it's a mirror image pattern of what we see when we look at the surgical or pathological nature of what the sinus 1 and sinus 2 is. Sinus 1 and sinus 2 remain the same no matter how you look at them. But when you look at them from below, you have to invert your hands in order to see which sinus is which. And it's just an important thing to remember as an echocardiographer that you really have to invert the echocardiographic images as if you were looking at them from above, or you have to switch the hands, in which case the right coronary artery arises from sinus 2. But that's the only point that I really wanted to make. The other interesting issue is the very end of your session, the close cousins provide a great deal of difficulty for ultrasonic diagnosis. And one has to be very careful about looking at the alignments versus the connections, or the atrioventricular connections, in order to make an appropriate diagnosis. But a wonderful session, again, with tremendous depth, and fortunately, I'll have the YouTube to look at again and again. Thank you.
Well, thank you for those comments. Adrian, you've not on the plane yet.
No, I've just arrived.
So where are you now?
In Bergamo.
Oh, well done. Congratulations. You've
Yes.
well. Were you able to watch the presentation?
Yes, most of it, yes.
Do you have any thoughts or comments?
Yes, thank you very much for allowing me to talk now. Apologies, Diane, because my connection will end. I just wanted to congratulate Diane again for the wonderful images, really, really extraordinary hearts. And then to you for touching on the fact of the discordant connections versus discordance. And maybe we can discuss a bit about what feels that atrioventricular septal malalignment, because it's the membranous septum, which loses its proximity with the conduction. And that's important, not only in the offset, because the reverse offset is important for echocardiographers when they look on the echo for CCDGA. But if you think about that, it's impossible then for the left atrium to reach the left ventricle in terms of connection for the conduction tissue when you have the reverse setting, because the AV node is still in the morphological right atrium. So I just wanted to point this out to people when they think about the conduction, when they think about the membranous septum and the large attachment of the tricuspid valve and what happens with that when you have to do the PA banding. Because PA banding is an important element for the treatment of this pathology. And we know that that can change the tricuspid valve regurgitation and how it behaves. It's a wonderful session. Thank you for touching on all these complicated topics.
Well, thank you for your comments and enjoy yourself in Bergamo. We should mention that there is a remembrance of what would have been the 100th anniversary of Professor Lucio Parenzan, who was a wonderful man in the history of congenital heart disease. And Adrian is present in Bergamo. They are having a meeting to celebrate what would have been his 100th year. So thank you, Adrian, for joining us. And we should all remember the wonderful achievements of Professor Parenzan, and indeed the school that he created, and where you were one of the students. Would you like to say anything about the school?
Thank you. Yes, it's been a life-changing event for me and for many others like me, because we were probably several hundreds people coming from all over the world in this school. And we were very well welcome here, and we were very fortunate to actually meet people like you and many other surgeons and cardiologists who gave their time, came to Italy many times. And for me, it was indeed a profound professional career change. And I'm very thankful for people who made this possible. Thank you.
Indeed, you'll remember, Adrian, that the school was the Kirkland School, and it was a joint venture between Professor Parenzan and John Kirkland, who was in many ways the father of pediatric cardiac surgery. And it was, as you say, I was very many times in Bergamo. I'm just sorry I can't be there myself, but it is good that you are there to represent us. So please give everybody our best wishes and tell them we are remembering Professor Parenzan, and everyone from the Congenital Heart Academy our wishes are with you for the meeting in Bergamo.
Absolutely. Thank you very much.
Diane, do you have any thoughts? As Adrian said, your presentation today was quite spectacular, as it always is. The hearts were wonderfully shown, and I think you made all the significant points. Do you have anything to add?
I don't know. It seemed like I was a bit long-winded today for some reason.
I think we were all a bit long-winded today, but it was well worthwhile.
No, I don't have any additional comments. I just think that putting together your PowerPoints and being able to show the specimens really brings some of this anatomy and concepts together very well. So I really enjoy participating.
We have one question, in fact, from Jason, who is frequently with us, and he usually asks very good questions. And he poses the question, how is the course of the coronary sinus in congenitally corrected transposition? And that's a very good question, because, of course, the coronary sinus in the normal heart drains the blood from the morphologically left ventricle. In congenitally corrected transposition, the coronary sinus remains in the left-sided atrioventricular groove, draining into the morphologically right atrium, but now it drains the blood from the morphologically right ventricle. So it no longer receives the blood from the great cardiac vein. So it has subtle differences, but it's still present within the morphologically within the left-sided atrioventricular junction, and it still drains the blood into the morphologically right atrium. So a good question from Jason, and another of the subtle differences that we find in the presence of congenitally corrected transposition. Sasha, do you have any more? Is Sasha still with us, or has Sasha disappeared?
Looks like he's disappeared, Bob.
It does indeed. So it seems I'm in charge at the moment. So we have no more questions. So thanks to everybody for being with us. I should tell you that the end of November, on the 22nd of November, we're going to have our next session for this autumn series, and we're going to talk about what is double inlet ventricle. So a close cousin, as we've heard today, but next time we'll discuss the variants in double inlet ventricle. Thanks to Diane, to Adrian, to Norman. Thanks to all of you for being with us for what indeed was a spectacular session. And hopefully now you all know what is congenitally corrected transposition. So thank you and goodbye.